All right. Well, it is noon central, so we'll go ahead and get started. We like to welcome everyone to our second installment of our webinar series here at the National Center for Cannabis Research and Education. My name is Robert Welch. I'm the director, and we have a really special guest today. Dr. Ryan Vandrey is going to do a really informative presentation on the National Cannabis Study and the Cannabis and Health Research Initiative. I would like to give a brief bio and introduction for Dr. Vandrey. Dr. Ryan Vandrey is currently a professor at the Johns Hopkins University Behavioral Pharmacology Research Unit and helps run the Cannabis Science Lab. His research focuses primarily on the impact of route of administration, dose, and chemical composition of cannabis products on resultant drug effects and pharmacokinetics. In addition, he has been involved with a broad range of studies related to the risk and benefits of medicinal cannabis use, cannabis drug interactions, the effect of cannabis use on sleep, cannabis withdrawal and treatment of cannabis use disorder, cannabis product testing, and developing measures of cannabis use behavior. So this is a really good topic today, and we hope that you can be engaged and please be sure to put any questions you might have in the Q&A, and we'll get to those at the end of Dr. Vandrey's presentation. But we'd like to thank Dr. Vandrey for presenting today and being here with us. And I'll hand it over to you, Dr. Vandrey. Thank you, Ryan. Appreciate it.
Thank you very much for the invitation, Dr. Welch.
Thanks.
Happy to be part of all of this and talk about some of the new work that we've been doing up at Hopkins. So just to begin with, I have some disclosures. Nothing really relates to the topic of discussion today. So I want to just kind of start with a little bit of a background to kind of get us on the same page in terms of why we're doing what we're doing with the Cannabis and Health Research Initiative, and talk a little bit about the preliminary studies that kind of led us to where we are, and then just talk about this program that we've been building here over the last 2 years. So as most people are aware, cannabis is being promoted as a potential therapeutic for a variety of health conditions. And cannabis products are incredibly diverse and varied and increasingly diverse. And so one of the things that kind of we're faced with right now is how to understand how to focus research efforts and how to move forward with integrating cannabinoids as therapeutics in the context of this incredible diversity. And so we're a lot of the discussions we're talking about cannabis as a singular entity, but it really isn't. And so as any practitioners out there understand and appreciate, you can't just say medical cannabis is good for this, that, or the other. So it has to come down to a nuanced understanding of which particular health condition people are thinking about, and then which particular product from the variety of options available are you going to consider. And so the National Academies of Science, Engineering, and Medicine issued a report 8 years ago that summarized the data on the health effects of cannabis and cannabinoids and did a very fantastic job of doing so. And what they found was that there was conclusive or substantial evidence to support the clinical use of cannabis or cannabinoids for chronic pain, multiple sclerosis, and nausea or emesis due to chemotherapy exposure. There is moderate evidence to support short-term use for sleep dysfunction. It's found to be ineffective for dementia, glaucoma, depression associated with pain or multiple sclerosis. And then shortly after that report came out was when multiple regulatory agencies approved Epidiolex, or a pharmaceutical form of cannabidiol, for the treatment of rare seizure disorders. Now, in the last 8 years, a lot has changed. And again, the limited evidence here, this report kind of showed that there's a lot that we still need to understand in this area. And so that's one of the things that we've been trying to focus in on and understand, well, how do we move the science, how do we move the field forward, how do we better provide the necessary information for patients and providers to make clinical decisions about whether or not to use cannabis as a therapeutic. So the limitations of the existing data then and now remain that most of the controlled clinical trials that have been done with individual cannabinoids and not whole plant cannabis products. Most of these clinical studies have been relatively small without comparisons to alternative treatments. So you don't have kind of a positive control comparison condition in most of those studies. We're still lacking a lot of information on which product to choose, what dose, what route of administration for many of the health conditions for which people are considering therapeutic use of cannabinoids. And we're still trying to understand the mechanisms. How does THC, CBD, terpenes, and other minor cannabinoids interact with these specific health problems to either attenuate symptoms or treat the underlying etiology of the disorder? And so when we think about that, what's the right approach with all of this? Yes, could we do large controlled clinical trials for the myriad health conditions across all of these varieties of products? But that's an amazing amount of investment in funding and resources and time. And even at the end of some of those RCTs, we might not be able to generalize to other products or other health conditions or other patient populations. So I think the therapeutic use of cannabis is the prime example of how we can use real world evidence to evaluate at a very broad macro level the impact of this diverse product category of therapeutics across a bunch of different health conditions, to try to identify particularly useful targets to then bring back into drug development and to do the controlled clinical trials. So what we're thinking about when we're talking about here in terms of real world evidence is, because cannabis has been legislatively approved as a therapeutic in most US states and in many other countries, we have the opportunity to collect data from real patients using real products in real time to then understand where there's particular promise, where there's a complete lack of evidence, and where there's potential harm. And we do this by evaluating what kinds of products certain patient populations are using, tracking them longitudinally over time, and understanding health effects at a very large scale, but on a level that's substantially cheaper and faster than running a controlled clinical trial. And I'm going to point out here that we've been doing this kind of work largely in collaboration with the Realm of Caring Foundation, which is a nonprofit based in Colorado Springs, Colorado. So what I'm going to do is talk through a few preliminary studies that we've done kind of leading up to where we are now. The first was an observational research registry that was conducted with Realm of Caring, and we've got several publications based on this data that are out there. I'm going to show you some data right here where we basically took people who were medicinal cannabis users or who were non-cannabis users but were contemplating the therapeutic use of cannabinoids for a variety of different health conditions. And we took these cohorts and they were matched on pretty much every demographic variable that we could identify. And we compared them on some basic assessments of health and functioning. And what we found in this initial comparison was that the cannabis users had better ratings, self-reported ratings of quality of life, pain, sleep, anxiety, and depression compared with the demographically matched non-user controls. The cannabis users were also using fewer prescription medications and were less likely to have gone to the emergency room or be admitted to the hospital in the prior month. We then broke out and looked at specific patient cohorts within this group of individuals, and we found that folks using artisanal CBD products had fewer medication-related adverse events in their treatment of epilepsy. And folks who primarily were using or were interested in cannabinoids for mood disorders, anxiety and depression in particular, showed improvement when they were a non-cannabis user at baseline and then initiated cannabis use, and we followed them up. So we saw less overall depression independent of kind of where they were at the beginning in people using cannabis versus not using cannabis. And then when non-users initiated, we saw significant reductions in anxiety. So with that kind of initial anxiety and depression cohort, we wanted to do a more detailed longitudinal follow-up of new cannabis initiators in the state of Maryland. This goes back a few years when the state of Maryland first adopted a medical cannabis program. And we did is we recruited 33 people who were not using cannabis, had very minimal prior history with cannabis, and we followed them for several months. We had them fill out diaries using an app on their smartphone every day for 8 weeks. And we asked them, questions about their mood generally on a monthly basis, but then also about what products they chose to use, what doses, and what the effect was in real time for 8 weeks. And what we found is that when people acutely used a variety of cannabis products, they used it a variety of ways. So some smoked, some vaporized, and some orally ingested the products. It was a relatively equal distribution across those 3 different methods of use. And compared with right before they used an acute exposure to cannabis to right after, they reported an increase in the subjective feeling of being high, but they also had acute reductions in anxiety and depression. When we looked at the effects by THC dose, this cohort of individuals, because they were registered with the Maryland Medical Cannabis Program, were specifically interested in using THC dominant cannabis products. And what we saw is a kind of an inverted U-shaped function in terms of dose and suppression of anxiety or depression, where the maximal attenuation of mood symptoms occurred at a dose range between 6 and 15 milligrams when taken orally. When we looked at this cohort longitudinally, and this was a bit surprising to us, is that we not only saw an acute reduction in anxiety and depression symptoms with use of THC dominant products, but it was sustained for up to 6 months. And so this was really a good demonstration of not only therapeutic use of cannabis having kind of an acute positive effect, but that there wasn't the development of tolerance or a flip and an exacerbation of anxiety or depression with long-term consumption. And I do want to point out that this cohort was not using cannabis on a daily basis in most cases. So it was kind of infrequent use as needed when symptoms were particularly strong. So, and then my colleague Johannes Thrulen has been really focused in on using this ecological momentary assessment, the use of phone data to track health effects of individuals over many years. And I'm going to show you just a couple of slides demonstrating the feasibility of doing this. This is his data from a study evaluating patients who use both prescription opioid and medicinal cannabis to manage chronic pain. And it shows that you can have people reliably use their phone to give you good data, which just demonstrates the ability to collect this real world data in real time in large cohorts of people. And again, what was fascinating as an outcome of that is that the participants reported greater pain relief on days that they used both cannabis and opioids compared to cannabis only or opioids only, and that the cannabis was better than the opioids only. So just kind of showing you highlights of how people are using these products in real time. Now, we also know from other research that there are lots of quality control issues with cannabis products. So collecting data on dose information has been challenging, and we know that some of the risks and some of the potential adverse consequences of medicinal cannabis use relate to actual quality control issues with those products. There have been a number of studies that showed dose label inaccuracy of the products, as well as the presence of biocontaminants. Related to the dose label inaccuracy, on evaluation of products that we've looked at in terms of CBD oils purchased over the internet, we found a huge range of CBD concentration per milliliter of liquid across a range of products. We tested 84 different products and found 1.3 to 800 milligrams per milliliter concentration of CBD per milliliter of oil. And that's important because most of those products look the same, advertise the same, but have grossly different concentrations of the active drug in the product. We've also done evaluation of topical CBD products and shown again very poor dose label accuracy. And a lot of unsubstantiated health claims made on the labels of these products as well. So product testing and surveillance and quality control is another area of concern. And so a few years back, NIH had a request for applications to try to come in and understand the health effects of medicinal cannabis use. And Dr. Thruel and I put together an amazing team of scientists to help put together a really large and comprehensive program to try to get at that question. What are the health effects of medicinal cannabis use? And we're trying to triangulate a lot of the research methods that I just showed you from those prior studies to try to integrate on a singular platform and a scalable platform to help us move this forward and to scale things up at a larger level. So if you use that QR code, it goes to the website that describes all of this stuff in more detail. And I'm going to kind of walk you all through different components and projects of this cannabis and health research initiative over the next handfuls of slides. So as I mentioned, we've got a huge team here. Again, we are continuing to work with the Realm of Caring Foundation. I want to give kudos to Dr. Matt Lowe, who's the principal investigator on the Realm side, and Sasha Kalchev-Korn, who's the operations director at Realm of Caring. And then we have a whole host of faculty and staff here at Hopkins and at Realm of Caring, and a great external advisory board of outstanding people that help guide what we're doing. So what are we doing? So one of our first thing is to really kind of get at measures development and developing tools for the larger scientific community with a specific aim of trying to get like-minded scientists doing similar projects and types of research the right tools they need to quantitatively assess cannabis use behavior, and also to try to bring us together in terms of commonality of assessments being used in this kind of research. Another thing that we're doing is we're taking that evaluation of medical cannabis patients and following them longitudinally in their journey of exploring cannabis as a therapeutic, and doing it longitudinally in adults who are newly initiating medicinal cannabis use. So again, there's lots of cross-sectional studies evaluating cannabis users versus non-users, but there's a lot of bias involved there. There's a lot of limitations involved with that research approach. And so while this probably, I know it doesn't fully get to the same amount of rigor as a controlled clinical trial where you have placebo and maybe a positive control, but it gets, I think, really, really close in terms of being able to get baseline evaluations of these folks and then following them as they transition from no cannabis use to therapeutic cannabis use, and then continuing to maintain and follow them over time using web-based surveys, the phone-based apps, and some biomarkers. I'll get into a little more details there. We're also very interested in looking at electronic health records as a source of data for evaluating all of this. And I'll talk a little bit about natural language processing tools that are being developed with the research team here at Hopkins to probe the electronic health records. And again, have this as something that can be scaled up and used by other folks. We're developing a data repository to serve as a research resource tool for other scientists. And I will get into a couple requests from folks listening there in terms of collecting data from scientists once they're done with it, and then also availability of this data and how we're archiving it for other people to use. We're continuing to build out our program of retail product surveillance and testing, and we've built a library of publications specifically on medicinal cannabis use as another resource for folks. So to start with, and kind of go back to the beginning of our first priority in all of this, was really kind of recognizing some limitations of the existing research that's been done. Cannabis Use Questionnaire is something that we developed as part of the Realm of Caring project. There are validated assessments of cannabis use out there. Kerry Cutler's DeFACU, and then the timeline follow back is a gold standard in measuring substance use behavior. The limitations of those are that the Cutler instrument doesn't have the full spectrum of retail products that are currently available and being used in the program, even though it's very structured and quantitative. And the timeline follow back is very unstructured. And so while anybody can say, I use 2 edibles and 3 vape products, researchers are using it differently. The units of measure are different. And so we needed a structured and fully comprehensive questionnaire. And so we've built that. And it's now available for people to use. We have a validation paper coming out, hopefully very soon. And so what we're trying to do is making this kind of thing available for scientists to use broadly. This is free to use, free to download. So what we do is we first ask people about 9 different general product categories. Is the product that you're currently using cannabis flower, e-liquid, concentrate, oil, edible, topical, suppository, pharmaceutical product, or something else? So this is totally, even if something new comes out, there's an other category where people can type it in, and we'll add it to the options later. Then we focus in on the chemotype. Is this a THC dominant product, a CBD dominant product? Does it have both, or are they using separately both THC and CBD products? Did they not know what the cannabinoid content is? And that is the case for a surprising number of people using cannabis for therapeutic purposes. And then there's a number of minor cannabinoids that are being promoted and are more readily available and being used. So we're capturing the chemical composition, the formulation, the route of administration, and then we go into extensive detail about all of the products, right? So how many different products in each category are being used? Where was the product purchased? How long have they been using it? What's your typical dose? And the dose is specific to a unit of measure that matches the route of administration and product type in terms of how they're usually labeled. So an edible would be milligrams of THC and CBD. Inhaled products is different. And so within the questionnaire, we get all of this information, and then 7-day detail use history, similar to the timeline follow back, is also captured. I do want to mention that this is not a cannabis use history in terms of lifetime, but it's focused on people who use cannabis at least once in the last 30 days. The QR code shown here goes directly to our website where the product can be downloaded, the questionnaire can be downloaded, and it's pre-programmed in both Qualtrics and RedCap. So you can download it and import it directly into your accounts for either of those databases if you use them. And if you don't, there's a form where you can get detailed instructions on how to program it if you have a customized database. And we're happy to help with any of that other stuff. So in addition to measuring cannabis use behavior in the same way across studies, we're very interested in scientists measuring other general health outcomes in the same way. Now, there's lots of different validated assessments of pain and sleep and quality of life and functioning, and they're all great. But when every research group is using a different one, it makes it challenging to compare results across studies. And it also makes it challenging to integrate data across groups and publications for systematic reviews. and all of those kinds of things, right? And so what we're trying to do here is evaluate all the validated assessments for some kind of core health domains that are relatable and relevant to therapeutic cannabinoid use. And we evaluated these things in a very specific way to try to come up with a recommended core assessment battery. And this was based on accessibility, cost, validation, prevalence of use in the previously published literature, adaptability in terms of different languages and translations, and brevity. So minimizing the burden on the participants doing these things. And so the end result of this evaluation is that we identified core areas being quality of life, functioning, general health and well-being, pain, mood, sleep, and cannabis use behavior. And so listed here are the items that basically made the cut in terms of our recommended core assessments. Now, this doesn't mean that everybody has to use only these measures. So for example, if you're doing a research study on pain or people with chronic pain, please use the brief pain inventory short form in addition to any other specific pain assessments like pain catastrophizing or things like that. In addition, there are some ancillary things related to cannabis use, motives, expectancy, and misuse that we recommend people use if that's something that's relevant to the patient population that you're studying, or if all of the patients are actually using cannabis. And so again, to make things easy and so people don't have to scramble to write all of this stuff down right now, we have a QR code here that goes to a page on our website that has every item that we recommend and why, and step-by-step instructions on how to get the appropriate permissions to utilize those assessments from the developers. So these are not tools that we've developed. It's just rather a recommendation for a core assessment. And then you can follow the step-by-step instructions for getting access to those tools. And if anyone on the call is interested in using these things and is using REDCap or Qualtrics, reach out directly to myself, Johannes, Serena, anyone on our study team, and ask, and we can share an export of our programmed versions of each of those instruments in either REDCap or Qualtrics. Now, we can't put those exports directly on our website because of copyrights. We don't own those instruments. But once you get the permission from the developers, we're happy to share the programming with you. So moving on to the next aim of our bigger project is, again, to scale up this evaluation of therapeutic use of cannabis among patients and evaluating longitudinally in real time what's the impact of making this decision to a variety of patients for using for a variety of health conditions. So we have IRB approval, and we're currently recruiting for a large longitudinal observational research study. We are targeting 10,000 patients to be captured in this study. And we plan on collecting data from people before they initiate therapeutic cannabis use. We're looking for people who self-report at the beginning that they intend to initiate within the next month. Now, sometimes it takes a little bit longer than that to get enrolled in a state-regulated program or to get access to the data or just to start using it. So we account for that. And then from the time that they begin medical cannabis use, we do follow-up assessments 1, 3, and 12 months after that time. Now, in the larger cohort, we're doing web-based surveys. A lot of, we're using that core assessment battery. And in addition, we have health condition specific additional questionnaires. And then we're pulling out a subgroup of the larger sample of participants to do the phone-based app bursts for 1 week around each web-based larger survey. So we're going to get really detailed momentary daily data from 500 patients with diagnosis of chronic pain, anxiety, insomnia, or PTSD, and what product are they using? When are they using it? What dose? How is their sleep, pain, mood functioning, and all of that kind of stuff in real time? And then we have another sub group that's doing biomarker testing at baseline and at the 1 year follow-up. So we can look to see is, in addition to the self-report, okay, my chronic pain is this, my anxiety is that, but are we seeing corollary changes in inflammatory biomarkers? Are we seeing changes in diabetes risk or liver functioning and things like that? And then another component of all of this is we're working with folks at Ole Miss, Dr. El Soli in particular, to do additional cannabis product testing. So our surveillance product testing, it kind of has a couple different components to it. But one of the components is that participants in this study, if they report a particularly strong or an unexpected adverse event, our intention right now is to get a sample of that product and get it analyzed by Dr. El Soli so we can see, is the adverse event related to there was a lot more THC than the participant expected in that product? Is there another contaminant in the product? Does that relate to the adverse event? So to date, and this is a little bit out of date, but as of about a month ago, we had 127 participants in the study so far. 75 had initiated cannabis use and completed the 1 month follow-up, 37 completed the 3 month follow-up, and we had our first person complete the 1 month follow-up. So we had some pilot testing last fall, and that initial cohort is just coming up on their 1 year anniversary and completing the study. We've got mostly female participants and a mean age of about 46 years, mostly white or Caucasian folks. I think generally representative use of alcohol and nicotine or tobacco. And interestingly enough, only about half are reporting that the medicinal use of cannabis was explicitly recommended by their doctor. So we got about half of the folks engaged with their provider in this, and almost half are just going at this on their own. Maybe they were recommended by a friend or a relative or something like that. And only half are enrolled in state cannabis programs. So we're capturing data from folks that otherwise we wouldn't have information on. And I think that's important for as part of this broader program so that we can look at, do these folks that are enrolled in medical cannabis programs differ from the folks that are not enrolled, or the ones that are engaged with their provider and with respect to their cannabis use versus not. So the primary health conditions that these folks are using for are chronic pain or anxiety and depression. So that's not surprising. That's been reported in many other surveys. But I think that also just points to the representativeness of this cohort initially. And we're getting people from all 50 states and US territories. So we're really looking to have this be broad and representative over time. And the types of products people are reporting being used here also map onto data that have been reported by other folks. A lot of edible use, a lot of flower use, some people using vape cartridges, some topical use, and a variety of THC dominant, CBD dominant, and a combination of THC and CBD. Now, we don't have enough people to do quantitative analysis of outcomes yet, but using the mother's eye, so to speak, in terms of just eyeballing the initial data we have, a couple striking things stood out to me. One is that most of these folks are using other medications. So a lot of people in the cannabis industry promote substituting medical cannabis for other medications. In my experience across multiple studies, that's typically not how patients approach medical cannabis use. It's typically used as an adjunct to other medications that remain stable. And that's what we're seeing so far in this cohort. Now, over time, we may see reductions in concomitant medication use, but as of now, we're not seeing initial full replacement or substitution. We're seeing some qualitative reductions in pain interference, anxiety and depression, and healthcare utilization, even as early as 1 month after initiation of therapeutic cannabis use. And we're seeing some within subject improvements in sleep and quality of life being reported. But I do want to point out right now, these are very preliminary. The magnitude of these changes are modest at best. And these outcomes are collapsed across patient cohorts and product types. So as we build up the numbers in this study, we'll be able to break this down into patient cohorts based on the kind of health condition they have and the kinds of products that they're using to get more detailed information out that can help inform clinical practice. We need help from anybody, any providers out there. Healthcare providers are the best source of referrals for us. So if you're a provider who sees patients who are considering medicinal cannabis use, please make them aware of this project. We need to capture people at a very narrow window inflection point of where they've got a health problem, they've tried other things, now they're considering therapeutic use of cannabis. We need them there. If we wait too long and they already start, they're no good for this particular health study. So please share this information with other providers you might know. Let me know and contact me if you have other good outreach resources. So we're trying to reach out to a number of professional societies and organizations and state medical cannabis programs, but any leads on this would be really helpful. And again, this QR code leads you to the website, which is the direct patient portal for getting enrolled in the study. I mentioned earlier, electronic health records is a particular area of interest for us because it's an existing source of data. And there are artificial intelligence tools that can be utilized to scale up and to make use of this wealth of longitudinal data on health. Now, the challenge in all of this is that medicinal cannabis use is not always communicated to the provider. As I mentioned earlier, only about 55% of the people in here were specifically recommended to use cannabis by their provider. The other 45% might not even be telling their providers about it. So it's up to the providers to start asking patients specifically, are you using cannabis? Are you using therapeutic cannabis? And then documenting that in the electronic health records. Now, most people are recording that in the clinical notes. And there are large language models that can be developed and validated to scan the clinical notes. And we've got an outstanding computer science team here at Hopkins that has done just that. So we got IRB approval to get access to the clinical notes for over 800,000 patients in the Hopkins health system that have a diagnosis of chronic pain, mood disorder, anxiety, PTSD, epilepsy, or autism. And we ran these notes and identified 171,000 cannabis users, 44,000 where the note explicitly mentioned that it was medicinal in purpose. So right then and there, we've got 44,000 participants in a study that we can utilize other data in their electronic health record to evaluate the potential health impacts of therapeutic cannabis use. The kinds of example notes that we're using and how we're using these algorithms. So if you have an example, and this is a made-up example, a patient is utilizing a 1-to-1 THC to CBD tincture, about 20 milligrams total, twice daily for neuropathic pain, secondary diabetes initiated 2 months ago. We can train these algorithms to identify and break these 44,000 people into the type of cannabis they're using, the route of administration, the dose, the frequency, and the health condition. And then we can generate comparison cohorts to then evaluate whether these folks differ on concomitant medication use, on healthcare utilization outcomes, and look at this on a macro level of, is therapeutic cannabis use helpful, harmful? Is it cost beneficial at a systems level? And so this is the kinds of things that we can do beyond just surveying medical cannabis users. To help with all of this, we've also developed a new smart form in Epic that providers are starting to use here at Hopkins. Now, this is a very slow rollout. We have to go literally clinic by clinic and try to convince physicians to utilize this thing. But this is a short form that exists within the electronic health record that captures the kind of important data we were talking about earlier. Are they using cannabis for any reason or not? Is it for therapeutic purposes? Is it THC dominant, CBD dominant, or something else? What route of administration, how often, and if it's for medical use, what purpose? Now, the cool thing about this smart form is the provider can fill that out during a patient meeting the first time they see the patient. Takes 2 minutes at the most, 10 seconds if the person says, no, I don't use cannabis. But then the cool thing about this smart form is it remains populated. So the next time that provider sees that patient, the form pops up. It's already populated with whatever the patient told the provider last time. They can make changes to it, update it, or just if everything's the same, you leave it alone and move on. So it becomes faster than typing out the clinical notes over time. Every change in the form gets archived, and then that becomes a really valuable source or resource for us doing research within the health system and the health system electronic health records. So folks outside of Hopkins, if you're interested in this, please reach out to me, because there's a process by which you can request use of the JHM brief cannabis assessment, and our Epic provider can export the form directly to your institution. So on the electronic health record side of things, we have fine-tuned multiple algorithms in terms of the LLMs. We're working on identifying these comparison groups for cross-sectional comparisons. And we plan on, once we finish validation of each of the LLMs, we're going to share them so that they can be pushed out and utilized in other health systems. If folks are interested in collaborating, please let me know. All right, another resource that we have is the CHRI data repository. I mentioned this, alluded to it earlier. So once we begin kind of harmonization of assessments, harmonization of data approaches, we can start compiling data sets and doing big data analyses. So this gets to the size of what we can do in electronic health records, but it's more quantitative, it's more structured, and it's more specific. So what we're doing is we're collecting data from anybody doing research within the general area of health effects of medicinal cannabis use. If you have data, please let me know. We would love to collect it. We coordinate that through the Hopkins Office of Research Administration, the formal data use and data transfer agreement. And then once we collect enough data from other folks, we have a grants program. We've got funding to support junior scientists interested in working with the data. So please, if you collect data, you run a research project, you've written your paper on it, it's just sitting collecting dust, we would love to have it. It's very minimal on your end. The advantage of sharing with us is that we promote what you have done. It'll increase citations for your publications, and it just kind of gives back to the scientific community. So I think I just said everything that was on this slide. I mentioned earlier product surveillance testing and how we're going to continue doing evaluation of cannabis products, specifically for people who are in our longitudinal study and experience adverse events. But we're also going to do random sampling of retail products and products seized from law enforcement. And again, this is a direct collaboration with the University of Mississippi, the El Soli laboratory down there. And I mentioned earlier that we have a research library. So I'm sure everybody here has the familiarity with PubMed and other online research databases. You go in and you type in what you want, you get thousands of unrelated results. So if you're interested and very focused in on health-related cannabis research, you can go to our website and do keyword searches. All of the publications on there are cannabis related. They're searchable by keyword. They can be filtered by preclinical and clinical. The abstract for the publication is on our website, and then we have direct hyperlinks to the full publication going out. So where we're headed with all of this stuff, I know that was a lot, probably like drinking through a fire hose. I went fast just because I had to try to cover all of this stuff, but what we're trying to do here is to kind of build a platform for collaborative science. We want to increase the knowledge about the health impacts of medicinal cannabis use. so that we can identify areas of more targeted investigation and also areas where there's uh, really no strength in evidence where people should probably reconsider therapeutic cannabis use. We want to build resources to better facilitate science, to help collaboration. And we think about everything that we're doing as a platform for being scaled up and to working with other groups. So keep in mind that while we said we're doing this prospective study, we want to enroll 10,000 patients. I would love, and this thing has been intentionally built for people who are interested in what we're doing, but maybe have a particular interest in a certain patient population. Rather than spending another year to build the same data set and database that we've built, work with us, bring in some additional funding through an NIH grant, through a foundation donation or whatever, to help us over recruit that patient population that you're interested in, increase our sample size beyond 10,000, and we can negotiate a data use agreement to share the data back with you, or to come up with some other way where you can utilize what we've already done so that everyone's not reinventing the wheel. So think about how you might be able to utilize the resources that we've built, and please let me know. So again, there's a huge team that goes into this. And I want to, in particular, give a shout out to Heather Kimmel, who's the scientific officer at NIDA, who generated the request for applications and has been an integral part of this project and champion of this kind of work. In addition to all of the other folks that are essential to this. Clarissa Madar at Hopkins has built so much of this. Serena Dubois has done so much of this work. It's just really an amazing team. So with that, here's kind of websites and all of the other stuff, and I'm going to shut up and let folks ask questions, because I find after all of this, we can usually get into some pretty good discussion.
Yeah, thank you so much, Brian. That was great. That was really informative. And hopefully we have some questions. Can I see one coming in? But I had a couple of things I'd like to ask you real quick. So in terms of, I know that these are new cannabis patients, cannabis naive, I guess you could say. Um, is there any consideration of a washout period at all for anything like this, or is it just totally naive?
So it's not naive, and I do want that to be. So these are people newly initiating for therapeutic purposes. Our kind of threshold for that is they can't have any more than 5 instances of use in the prior year
Okay.
and none in the prior month. So folks that, smoked a bunch of cannabis in high school and college, and now they're 50 and facing chronic back pain, and they've tried other stuff. They've had adverse events related to opioids. Well, someone said try cannabis, and so now they're going to do that. That's an ideal person for us. What we don't want is people who have chronic back pain. They're already using cannabis daily, and then they come in, right? We're unlikely to see any change in that person over time, right? So we're really trying to understand people at that inflection of, I'm not, maybe, I went on vacation in Jamaica, 6 months ago and happened to smoke a joint and my back felt better. Maybe now I'm going to try it. Whatever, right? So very limited recent exposure are the folks we're looking for, because we want to know as you begin this, because the lens here is integration into medicine. We don't want the person who's been using cannabis for 40 years.
Perfect. Yeah, thank you. And I want to just go over this one particular question. I think you may have addressed some of this, but it reads on the 55% reporting the medical cannabis recommendation, does the question ask if it is their primary care physician or specialist? And then it says many people can get a recommendation through an online platform with a doctor that only sees them for the renewal or for their certification and not actively involved in their overall health care.
Of course, yeah, and we get that level of detail. So we ask, is it primary care? Is it a specialist? And what kind, right? So is it an internal medicine doc? Like we get all of that. It was just, I didn't have time to go into that level of granularity.
That's great.
And again, we're still relatively small. I mean, 130 people is a lot in the grand scheme of a longitudinal prospective study, but in the grand scheme of what we're trying to do, and given that this is a diverse group with all different health conditions, it's small. And so we can't split all of that stuff up just yet. But yes, we are getting that level of granularity.
That's great. And then I have one here that says, will the form inquiring about cannabis use integrate into EHRs other than Epic?
So our form will not, but we are happy to share the exact questions, the response options, so that folks that have a other than Epic electronic health system, you can build whatever this basically the same thing into your system. And I'm absolutely willing to give the questionnaire to anybody who wants to see it. And for our Epic developer, there's a little bit of fancy behind the scenes stuff that ensures that those answers carry forward and the form doesn't have to be filled out every patient visit with the same patient. But he can talk through how to do that, or if your electronic health record builder doesn't know, we can kind of help with that. But I can give you exactly what I gave our builder, and you can give it to your builder and just run with it. But I think that the important thing here is that having that kind of form will facilitate that conversation between the patient provider. And that I think is more important than anything. And the other reason that that questionnaire is valuable is that right now we rely on clinical notes documentation of medical
Yeah.
cannabis. The absence of a note doesn't mean an absence of cannabis use, right? But if we're asking specifically every visit and the patient says no, we've got a lot more confidence that they say no, that they're not a cannabis user. And that increases the validity of comparisons that we do within cohorts. We can say, all right, here's the people that said yes to cannabis and for therapeutic purposes. We're going to compare them to people that said no to cannabis. Because right now, what we're doing with our LLMs is we're taking clinical notes of people that said yes to cannabis for therapeutic purposes, and we're comparing it to anyone that is matched, propensity matched on certain things, and has an absence of cannabis, but we're probably diluting the differences because there's likely to be some cannabis users in our non-user control group.
Okay, that's great. And one thing that I just want you to clarify, if you don't mind, I think you did allude to this, and I think the way that you're doing it and have designed it, it kind of, and Dr. Bentley's on the call. He is with our Center for Pharmaceutical Marketing and Management. He will appreciate this, but I think you will be weeding out for lack of a better term, weeding them out. But folks that are taking, let's say, products that aren't found in a medical cannabis dispensary and they're getting them elsewhere, like these products that are available, that they're saying that's for therapeutic use, but they're coming from the vape shop or the convenience store and so forth. Is that being taken into account? I think it is, but I just want to clarify it.
So we are asking about use of all of those products. And I do want to emphasize that we want people who are using internet-based CBD oils and
Yeah.
the CBD store Delta 8 products or what if they say I'm using it for a therapeutic purpose, or if they say, I'm going into the state medical program, but then it's too expensive. So now I'm going to switch to buy that. I found that this worked, but now I'm going to buy it cheaper in, community market or whatever. That's interesting data. That's data that we need. And as that person switches products or sources of products, so we can capture that source in this cannabis use questionnaire. Is there differences in rates of adverse events, functioning, all of the stuff that we're interested in?
Yeah, that's great. And one other thing I wanted to just get you to clarify real quick. I know that when you're talking about Epic and other systems that has that integration, which I think is really important. And I'm sure that there's all kind of compliance measures with HIPAA and everything that have been taken into account. I just wanted to ask the question in case it comes up later in terms of HIPAA compliance. Is that fully been taken into account? I'm sure it has, but I just wanted to ask.
Yeah, so the way we're operating here is everything that we have is fully vetted and approved by the Hopkins IRB.
Yeah.
And then any data sharing or data use that we have is also IRB approved and managed through the Hopkins Office of Research Administration. So any reporting kind of coming in, there's a whole consent process for every participant. The other thing that I failed to mention that I think is important, again, any providers out there who would consider referring their patients to us, we are compensating these participants for everything that we're asking them to do. And so a lot of prior studies have relied on, everyone gets asked to fill out a survey by somebody 3 times a week at least, right?
Yeah.
We recognize the survey burden that everyone in the US is under right now. That's why we explicitly got the funding to compensate people, I think, pretty well for what we're asking them to do. And we hope that that's going to result in good engagement and good retention over the course of this study.
That's great. Yeah, thank you. I don't see any more Q&A questions that are typed in. If anybody has anything, we've got 4 minutes left while we have Dr. Vandrey. If you have any other questions, I will like to mention while we wait just a second there. I want to make sure. Oh, go ahead. Yeah,
I'll just say too, my contact info was, listed up there. Please, please, please feel free to reach out via email or whatever. And if you've got other questions beyond that, you just don't feel like sharing now or would be more complicated than 4 minutes.
Yeah, and thank you for saying that. And you're always very available and responsive, so we appreciate that. And I just want to make sure if you missed something or want to share this recording, and we'll post this recording to our website, and we'll have it available if anyone wants to watch it again or send it to someone who couldn't make it. That's perfectly fine with us. And since I don't see any further questions, did you have any final comments, Dr. Vandrey?
I think, the way I try to wrap this up and try to summarize this has got to be a team effort, right? This is too big for any one person, one group, one university to do. And so I really value that what you and your colleagues are building at the University of Mississippi and within the state of Mississippi. You've been really kind and interested in collaborating with us. We've got a similar thing with folks in Florida, folks in Utah. So we are very, very interested in helping this and taking a team science approach to all of this. Again, I look back and I'm shocked at the fact that California legalized therapeutic use of cannabis in 1996. And here we are in 2025 having mostly the same kind of conversations and having still huge unknowns and gaps in knowledge about how to do this the right way. So I think we're far beyond where we should be in terms of being diligent about getting in this kind of information. Are we helping people? Are we harming people? And who with cannabis? And I'm convinced now that there's absolutely there's tremendous therapeutic potential of cannabinoids in the endocannabinoid system. But I also recognize that we know next to nothing about exactly how to realize that potential. And so I think that that's where this becomes important. And if we're going to take this and we're going to move this forward and therapeutic use of cannabinoids is going to become realized and fully integrated into healthcare, it's going to take an army of people, and it's going to take a lot of translational work that comes together and utilizes all of the resources and sources of data that we have.
Yeah, thank you for that, and thank Dr. El Soli and his private lab for being involved as well. We're not testing him here at the university, but he obviously is an employee with us and has been now for many years. So we thank Dr. El Soli for that. And with that, I think we'll wrap up. I just want to mention one quick thing about next month. We're aiming for the week of November 17th. I don't have the date quite nailed down just yet, but we have the speaker. And so we look forward to sharing that with you as in the coming weeks before the holidays hit. So for our next webinar in the series. And Dr. Vandrey, great job. Really excellent information. We appreciate your time.
Thanks for the invitation. I appreciate the
Thank
platform.
everybody for joining. We appreciate it. Have a good week, everyone. Thank you. Bye-bye.